looks good.
Well, good morning, everyone. As Dr. Pitchler says, thank you for the invitation to Renal Grand Rounds. Today I'm going to talk about simultaneous liver kidney transplantations and the advent of something that's been referred to as the liver safety net. I have nothing to disclose except the fact that we don't get to see each other in person very often anymore, and so I take the brief moment to update everyone. This is Carter, he's now 7. This is Elliot, she is 5, and then Maddie is our latest addition. She'll be 1 in February. They're ready for Christmas, clearly. So, you know, on the face of it, it seems like this is a bit of a niche topic, but I think there probably is something here for everyone. So who is this talk for about SLKs and the safety net? So obviously it's for folks who take care of patients who have liver disease and kidney problems related to that. I would say it's more broadly applicable to folks who take care of patients with other types of what has been referred to as functional kidney failure. So towards the end of the talk, I'll talk about the relevance, particularly to those who take care of patients with cardiorenal syndrome. And it's highly relevant for folks who care for patients with end-stage kidney disease, because what we're talking about here is a finite resource, a limited number of kidneys that are available for transplantation. And if none of those fit, then it's for those who care about the just and equitable distribution of a scarce resource. And so hopefully it's a little something for everyone here. So the outline is, you know, first I want to talk about just a brief introduction to what I'm talking about when I say the safety net, because this is a policy that perhaps not everyone is aware of, and it's kind of the thing on which the rest of the talk will hinge. So the safety net, for those of you who haven't heard about it, was a policy that was enacted in 2017. Essentially, what it did was gave priority for kidney transplants to those who have had a liver transplant and then need a kidney in the first year after transplant. So the language here is that liver transplant recipients who are either on dialysis or have an eGFR of 20 or less between 60 and 365 days after their liver transplant receive priority on the kidney waiting list. Now, how high is this priority? So it's pretty darn high. So this is a chart indicating the sort of sequence of kidney allocation. And I'm not going to go through the whole thing, but it's broken down into sequence A, B, C, and D according to the quality of the kidney. So sequence A is excluded here. So the highest quality kidneys, this doesn't apply to. But for the, you know, that's just the top 20%. But for all the other kidneys, safety net patients or kidney after liver safety net patients are prioritized above all adult recipients. In sequence B here, they're prioritized right below local pediatric recipients. But you can see here for, you know, kidneys in the sort of 35 to 85% range, they're above all local recipients, pediatric and adult. And so really these folks are at the top of the list, below just the highly sensitized and prior living donor recipients. This is a huge deal, right? Because the obligatory slide about kidney transplants, this wait list is enormous and there are not enough kidneys to go around. And so even though the number of liver transplants that we're talking about per year is not a ton, somewhere in the 8,000 range over the last couple of years, if even a very small portion of those patients fall into this criteria after their liver transplant, then they are prioritized for kidney transplant and receive kidneys that would have otherwise gone to folks who were on the kidney alone transplant list. So that's the safety net in a nutshell. What I want to talk about is first, you know, how did we get here? So what is the historical landscape with respect to simultaneous liver kidney transplants, and why did this policy come about in 2017? We're not going to go quite back to 1963, but really what has happened in the last several decades that has brought us here. And then I want to talk some about what we've learned from the data so far. There's only a few years worth of data, but I think that there's some signals and some lessons to be learned. And then at the end, I'll talk about where we go from here, some questions for the future, particularly as we think about more broader applications of policies such as this. So we'll start here with the historical landscape. How did we get here? And let's use a couple of illustrative cases to think about this. So the first case is the case of a 55-year-old patient with NASH cirrhosis who comes in and is admitted with hepatic encephalopathy. The patient's being considered for liver transplant workup, and this is kind of our bread and butter here at Montlake, right? Patient's past medical history includes diabetes, hypertension, heart failure, and stage 4 chronic kidney disease thought to be secondary to diabetes. The patient has a baseline creatinine of 2.8, their eGFR is 21, some proteinuria, and has a little bit of AKI right now. So, without having any more details than that, if approved for liver transplant, is this a patient that should be considered for simultaneous kidney transplant? You can just think to yourself. I don't actually even have the chat up. So, think to yourself, should this patient be considered for kidney transplant? It's not a particularly controversial one here, right? So this is a patient who has relatively long-standing CKD, is going to be going through a major liver transplant, is probably not going to come out on the other side of that with well-functioning kidneys. And so this is a patient who, yeah, I think would be approved for liver transplant. In fact, this was a patient that was approved for transplant and ended up undergoing an SLK. So let's contrast that patient with our second case. So here we have a 48-year-old patient with cirrhosis, comes in with SBP. Again, this is bread and butter, has AKI in the setting of sepsis, and gets the typical treatments for a cirrhotic who comes in with AKI. First albumin, and then vasoconstrictors with norepinephrine for treatment of hepatorenal syndrome. But the kidneys get worse and the patient winds up on dialysis. And the liver transplant workup takes a little time, and this is not uncommon. The patient's volume overloaded, there's concern about the echo or the right heart cath, we have to take volume off. And so eventually the patient is listed for transplant, but at the time of liver transplant listing, the patient has been on dialysis for 4 weeks. And so my question to you about this patient is, should this patient be considered for simultaneous kidney transplant? And really the question underlying that question, I think, is what do we know about the likelihood that this patient is going to get better after transplant? So what do we know about recovery from HRS after liver transplant? So we know that patients do recover their kidney function after liver transplantation. This is an old figure from the early 70s showing a patient with hepatorenal syndrome who went to liver transplantation. You can see that prior to the time of their transplantation, they were oliguric, their BUN was 160. So they were in kidney failure. And after transplant, really very soon after transplant, in a matter of days, there's a marked increase in urine volume and all the numbers start to look better. And we see that on a weekly basis here. Patients do get better after liver transplant. Interestingly, it's also been established that in the late 60s, they took kidneys from patients who had hepatorenal syndrome. And when those patients died, they transplanted those kidneys into people who had functional livers, and those kidneys worked. It takes a little time, but this is one representative schematic where you can see that over the course of about 50 days, the patient comes off dialysis, and the previously hepatorenal kidney works in a recipient with a normal liver. Recovery from HRS requiring dialysis after liver transplant tends to be time dependent. So it depends how long you're on dialysis before your liver transplant. You can see here on the left, so if you're on dialysis for less than 10 days, about 94% of those patients recovered their kidney function afterwards. And it's, not quite as good for those who've been on dialysis for in the sort of 4 to 6 week range, but still, 88% of those folks are recovering their kidney function after transplant. There does seem to be a drop off after this 6 week period. And that 6 week thing is going to come up again. And so what I would say for this patient who's only been on dialysis for 4 weeks is that they probably shouldn't get a kidney transplant. Their likelihood of recovering kidney function after liver transplant is pretty darn good. And so with that in mind, would this patient have been considered for kidney transplant prior to 2017? So not should they, but would they? And this is where I get to tell you that it was basically the Wild West and no one knows what would have happened for this patient. So there was enormous variability prior to 2017 due to the fact that there were not standardized criteria for simultaneous liver kidney transplant prior to that date. So this is broken down into the 11 OPTN regions. We're region 6. And it's the percent of SLKs or percent of liver transplants that were SLKs. And you can see that it varies widely. We were actually the lowest, somewhere between 3 and 4% of our liver transplants were done as simultaneous liver kidney transplants. But there are regions that were as high as 13%. So just enormous variability. And when this was studied with a survey about 10 years ago, a long survey, you can see that the practices varied incredibly. So here are just a couple representative questions. So all the transplant centers were asked, what duration of AKI requiring dialysis do you use at your center to consider patients for SLK? 4 weeks, 6 weeks, or 8 weeks? And it's essentially an even split. There's a little lag in my cursor, sorry. So, you know, it's basically 1/3 each, and no standardization or sort of clarity about how those decisions are being made. What GFR level do you use to select candidates for SLK who have CKD? And you can see here too, this is all over the board. Maybe you can see it. So, you know, there seems to be a majority going for the 30 mils per minute cutoff, but there were some folks who didn't even use estimated GFR or measured GFR as a criteria, and some that used 40, right? So it's really kind of all over the place. This was interesting. So retrospectively, these folks applied a standard eligibility criteria. So they basically said, okay, so if we say that you qualify for an SLK if your GFR is less than 30 or you've been on dialysis for 6 weeks, what percentage of those patients who were quote unquote eligible would have been listed for SLK by transplant center? And you can see just an enormous spread here. So, you know, this is the number of SLK eligible candidates at a given center. So let's just take, you know, 40 here. And every dot here represents a center. So, you know, one of the centers would have listed about 50% of those for SLK, but one would have listed about 90%. So it's just really all over the map. And it seems that, you know, sort of across the board, somewhere around 70% of eligible candidates, according to this criteria, would have been listed or were listed for SLK prior to 2017. So why so much variability and why the push to transplant these patients without the clarity in the data? Well, we know that mortality in liver transplant patients who have AKI, particularly those who have AKI both before and after liver transplant, is higher than those who don't have AKI. And this separation happens pretty early on. And so what we'll hear from our transplant surgeons is that they're worried about the patient not doing well afterwards, both their allograft data and their patient survival data. That, coupled with the fact that the average MELD score at transplant has been increasing almost linearly over the last decade, we have a scenario where the rate of SLKs was increasing over, you know, 15 years since the advent of the MELD score, such that in 2016, about 9% of the liver transplants were done as SLKs across the board. And so we have to weigh now the fact that, yes, mortality is higher for liver transplant patients who have AKI on the one side, with the fact that we have this kidney wait list for patients who need kidney transplants and can't get them. And so how do we strike this balance is basically the historical context here. This brings us to 2017, when the governing bodies for transplant essentially put out a proposal saying that we are going to standardize criteria for SLK. So here's the really wordy version, but I'll distill this down for you. So essentially from 2017, August 2017 onward, a liver transplant candidate is eligible for SLK only if they meet one of the following criteria. They have to have CKD with a GFR less than 30, and they have to have had CKD for a period of 90 days, but not necessarily a GFR less than 30 for 90 days. Or a diagnosis of sustained acute kidney injury, either requiring dialysis or with a GFR less than 25 for 6 weeks, or metabolic disease. And this is a very, very small minority, but for example, primary hyperoxaluria. So you qualify for an SLK. And this is the stick, so to speak, but the carrot that came along with this was that we are going to provide a safety net. So if your patient doesn't qualify for SLK, but you think they would have benefited from an SLK, we will allow for them to be prioritized for transplant in the year afterwards, should they wind up needing a kidney transplant, to sort of assuage the fears that were coming about due to standardization of the SLK policy. So that's where the safety net came from. So what can we learn from the data that we have over the last couple of years since it was implemented? And specifically, I want to ask 2 questions. So what trends have we seen with respect to transplant rates, and what trends have we seen with respect to patient and graft outcomes? So SLK transplants decreased modestly. So remember, it was enacted in 2017, and you can see that the number of SLKs dropped in 2018, went up again in 2019, a little bit up in 2020. But when you sort of forecast based on historical trends, what would have happened without the policy, the thinking is that it probably did decrease, a modest amount. Clearly, registrations for kidney after liver transplants, which I'll in the slides refer to as KAL, increased significantly. So, it wasn't that no one was ever being referred for kidney transplant after liver transplant before. This was just happening sort of, years afterwards. But from, the point of implementation onwards, you can see really a very significant increase in the number of folks who were referred for kidney transplant after liver transplant. And unsurprisingly, because this is what the policy was designed to do, the number of kidney after liver transplants increased from about 2 per month prior to the policy to about 8 per month on average after the policy. So we're not talking about enormous numbers, but those are 8 kidneys, right? And so, that was a noticeable increase. If you look, sort of at the cumulative incidence of KAL transplantation for all liver transplant recipients, the solid line here is before the policy change. So, a very, very slow increase over the course of the 2 years following liver transplant. And here you can see really at about 6 months, there's this huge inflection post policy where people start getting transplanted. That said, the total number of kidneys transplanted or used for liver transplant patients looks to be static. So, this is the dark part of the bar is those kidneys that are used for SLK. The light gray is those that are used for kidney after liver. And you can see that because the SLKs have leveled off here, and even the slight increase in kidney after liver doesn't appear to have added, or continued the historical trend of an increase in number of kidneys being used for liver transplant patients every year. The 2020 data isn't complete here, and I'm not sure why, but the SRTR database always lags about a couple of years for transplant data, so we don't have all of 2020. The impact on the kidney alone waitlist patients is unclear, and I couldn't really find anyone writing much about this. I know there's some transplant folks on the call, and so they can correct me. I couldn't also find good data about whether there has been an improvement in what's been referred to as longevity matching. So I showed you at the beginning that The top 20% of kidneys were excluded from this policy, and the purpose there was to try to ensure that those were going to patients with the longest post-transplant life expectancy. Obviously, those patients are not liver transplant patients, right? But I couldn't find any data about whether this, whether there's a signal to suggest that that had been successful at this point. And what trends have we seen with respect to patient and graft outcomes? So obviously, or it sort of seems obvious in retrospect, the waitlist mortality for patients waiting for a kidney transplant after liver transplant has decreased because they are prioritized and they are not waiting as long. I think that's not the most relevant metric, right? But if you take the group of patients who were transplanted under the safety net and compare them to a propensity matched group of historical patients who underwent SLK instead of waiting for the safety net, it does not appear that there's a difference in survival probability. And so, a lot of this data is relatively nascent, but it does not appear at first blush that waiting for a kidney after liver increases mortality compared to getting an SLK historically. And this is perhaps the most interesting of all to me. If you look at kidney graft failure rates, the kidney after liver transplant allografts did better than SLK allografts for all patients who had a MELD greater than 25. And basically, the higher the MELD, the more likely you were to have kidney graft failure. This isn't surprising, really, because the higher your MELD at transplant, the sicker you are, the more likely you are to have post-transplant complications, and that's going to be hard on a newly transplanted kidney. But it's nice to see what we see in clinical practice, shown in the data, which is that that the folks who are transplanted afterwards have a decreased risk for kidney allograft failure compared to those who receive an SLK if they go into their liver transplant relatively sick. And so you start seeing, editorials like this, a safety net is in place, who should walk the tightrope, really suggesting that this is a risky proposition for the patient. But in fact, perhaps, and I think the story is yet to be, completely told, we may want to ask, should this become the norm? If your MELD is greater than 25, should we consider an SLK for you? Or should those patients be waiting until after their liver is transplanted, get the kidney in a stepwise approach to improve their allograft outcomes down the road? In the last 5 minutes, I'll just talk about a couple of questions about the future. So the first is, I think, can we further optimize renal recovery post-liver transplant? And this is where I get to shamelessly plug the kidney liver program, Dr. Pitchler and I. But I think that, one of the lessons that I've learned over the last 5 years is that really sometimes this takes patience, not patience, but patience. So we have a representative patient here that both Raymond and I cared for who had, some degree of renal dysfunction for about 7 months prior to a liver transplant. And, eGFR was well below 30. So would have qualified according to current criteria for an SLK. Did not get an SLK, did get a liver transplant right here, and needed dialysis for a period of about 5 months around the liver transplant, about 1 month before transplant, and then for about 4 months after. The patient was in the hospital for a while and then went home, but was coming back to dialyze with us regularly. And so if we were to apply the safety net criteria, this patient would have been eligible for transplant, kidney after liver transplant right around here, and yet wasn't transplanted and ended up coming off dialysis. And when I saw her 2 months ago, she had a creatinine of 1.2 and is doing great and doesn't have the, higher levels of immune suppression that are required for a kidney transplant as compared to a liver transplant, and only has one, transplanted organ in her body. So I think it was a huge win for her. I don't know what the right amount of time to wait is, but my personal feeling is that 60 days, based on our experience, is probably too short. And I don't know why my slides are kind of goofy there, but something in the 4 to 6 month range, I think might be more appropriate. I don't think that there's a groundswell of support for this in the transplant community necessarily, but at least, anecdotally, I think that we probably should be waiting longer than 60 days. What about living donors? So, it's, I think, fairly well established that living donor allografts are better for multiple reasons, but this is true in liver transplant too. If you look at patients who had a liver transplant who got a deceased donor, and those are the red squares, versus those who got a living donor transplant after a living donor kidney transplant after their liver transplant, they perform better. And yet what we have seen is that living donation has decreased in the post-2017 landscape. The orange or goldenrod bar here is the subsequent living donor kidney transplants within 1 year. And you can see that in 2017, it basically went to zero. There's been a very, very slight uptick since then, but we're doing nothing to incentivize living donor transplantations because these folks are getting kidney offers so quickly after they're being listed post-liver transplant. And so I think we probably need to rethink whether we incentivize living donation in some way. And then lastly, what policy changes should we anticipate from other multi-organ transplant programs, or when can we expect the kidney heart safety net? And I do think it's probably a when, not an if. So simultaneous heart kidney transplants are increasing, both in absolute numbers and as a percentage of total heart transplants. And when you look at growth of multi-organ transplants writ large, the main growth area is basically simultaneous heart kidneys. We are not seeing currently a big significant increase in simultaneous liver kidneys over the last 5 years, but heart kidneys are really taking off. And there's some data that this might not be best for the patients. So for patients who are on dialysis or who have an eGFR less than 30, it does appear that probably combined heart kidney transplant is better than what's being called sequential heart kidney transplant when you get a kidney after your heart. But for those who have an eGFR between 30 and 44, it seems that sequential heart kidney transplant, so waiting for a kidney until after your heart transplant is done, is certainly not worse. And there's some suggestion that it may be better. Again, because you're not having this newly transplanted kidney soaking up all the complications in the immediate post-heart transplant period. And so these discussions are ongoing. In the minutes from the most recent conference call from the multi-organ transplant committee, you can see that the safety net for heart transplants was the second item on the agenda. And in fact, they were also discussing a lung kidney safety net at the same meeting. So, I think that the standardization of SLK criteria is a good thing and was long overdue. I think that the safety net is a good thing for liver transplant patients, but that probably it needs, sort of some fine tuning to maximize the donor pool and minimize unnecessary transplants. We don't have enough data yet on how these policies are impacting the kidney alone transplant recipients. And I think just a reminder that it's all of our responsibility to sort of remain aware of these policies so that we can advocate for what's best for all of our patients. And it's 8:30, and that's all I have.
Thank you so much, Cary. There's a question in the chat from Raymond, which I don't know, Raymond, if you want to just ask your question.
Well, Cary, that was actually a really good talk. Thank you so much. I think you partially answered the question after I posted it. I mean, the question was really, we know that patients with AKI going into a liver transplant have a poor outcome than patients who don't have AKI. And then the assumption is if you get a kidney together, that things are going to be better. But I don't remember a study, but you probably are aware of it, that has actually looked at that. And I think you partially answered it after I had posted that question.
Yeah, it's a little bit difficult, and part of the reason, and I didn't really get into this, but the reporting of SLKs prior to 2017 was not standardized in the way that reporting for liver alones was, and so it's a little bit hard to establish a control cohort here because we're not comparing apples to apples. Those who got SLKs and those who didn't, who had AKI, aren't necessarily the same patients. But I think that if anything, kidney allografts do better afterwards. Whether patients do better afterwards, I think remains still to be seen.
Cary, I have sort of one question and just kind of comment or discussion comment. So, I mean, I'm not a transplant nephrologist. I haven't thought a lot about this particular area, but picturing myself as a patient on dialysis waiting for a kidney transplant with no liver disease, there's something about this that sort of feels like unfair. Like I'm a dialysis patient. My median survival is 4 years. It's not like being on dialysis is a healthy environment. And then someone develops liver failure and then gets a kidney transplant super quickly, right? Like how do people in looking at the ethics of this sort of answer that kind of fairness question? I don't know if I'm making any sense, but.
No, I think you're making a lot of sense. And, I didn't want to, editorialize too much, but I agree with you, right? I mean, and I don't know how the balance is properly struck. I mean, in a way, the safety net was offered because the priority was to standardize SLKs, and there was so much resistance to do that it was, offered as, a piece of a larger agreement, right? So we're going to put the safety net into place so that we can have you stop doing all these unnecessary SLKs with the hope that downstream we're actually going to be using fewer kidneys for liver patients. But I think it's a bit of an oblique way to address the fairness question. And that's why I think that now is really the time for us to be paying attention to this, because if we're concerned about unfairness with respect to this happening to liver transplant patients, then we also need to be concerned about it happening for heart transplant patients. And now is probably the time to speak up about it. And if we're concerned about it becoming the paradigm, right, ensure that that doesn't happen. Because Raymond and I, our bias is, let's just hold on. I think we can probably get these kidneys back most of the time, right? And so our utilization of the safety net has been very minimal, very minimal.
Can I just say one thing in response to Matt's question? I don't want to take up too much time, but it seems unfair, but the whole point of this policy is we don't end up wasting organs, right? If you didn't have this policy, when people then people have to go for SLK, and we know that when Cary showed, about 30% of these people die. We end up wasting these organs when people who need a kidney could be using it. I think this policy ends up being better than not, right? Otherwise, they'll end up doing SLK.
My question was more like the policy, in my sort of novice opinion, like doesn't go far enough. Like you're still, I think you're still sort of prioritizing the liver failure patients sort of quite a bit above people, waiting on dialysis.
But I think that comes from severity of disease. Like UNOS has a few, one is utility, the other one is severity of disease. And when you have multi-organ failure, your mortality is higher. So that's where it's coming from.
Yeah, the other thing is that the ethical considerations for transplant are not only equity. It's based on the final rule, which also, requires the best utilization of the organs transplanted and avoiding waste. And that's, at some level, you are right, Matt. And that's something that we deal with every day on transplant. Is this duality of doing the best for the patient in front of you versus doing the best for the population at large that we care, and us as stewards of kidney transplants in a way But from the policy and how this was developed, it was the fact that there was data to suggest that patients with kidney failure have a worse outcome after transplant in terms of survival. That was the main driver of this, and the reason for this policy. It's better. I think it's definitely a step forward from, you know, not wasting kidney transplants. You know, there were transplant programs, as you mentioned, Cary, had up to 25% of their liver transplants was SLK. So that was obviously a waste of kidneys in that category, and has put some breaks in there. Maybe it has not done enough, as Matt is suggesting, and I think we need to keep evaluating. But it is definitely a step in the right direction. We need to have the same policies for the lungs and for the hearts, especially for the hearts. That's probably one of the biggest challenges we deal with right now.
Well, thanks Juhan and Nikolai for those thoughts. I appreciate that this is such a challenging area ethically that you guys have to think about and deal with every day. And thanks, Cary, for that overview.